Welcome everyone to today's session. We are joined by Professor Belinda Beck. Just a quick intro about Belinda. So she's a leader in the field of using exercise to prevent fractures and improve bone density in osteoporosis. She supervised the landmark LIFTMOR and LIFTMOR-M trials, and she's a co-founder and a director of the Bone Clinic and the Onero Program, which we'll talk about more today. So thanks for joining us, Belinda.
Pleasure.
So what I think a great place to start is talking about the LIFTMOR trials and how they came about. What made you want to run them, and what were you looking for when you did them?
I suppose it was sheer frustration. The bone world had semi come to a conclusion that we all knew that exercise is good for bone, like it's good for any tissue in the body. But there was, of the many interventions that had been done, nobody really showed you could grow bone particularly in people who already had low bone mass. And this is very frustrating to me because the people who needed it most were getting the least help. So I went back to basics, thought about the principles behind osteogenic loading or loading that will grow bone. And all the animal data showed us that it needed to be high intensity. It needed to induce greater strains in bone than you normally experience in your daily life or even in the exercise program you do. And a strain is actually a measure of bending. So it actually needs to bend your bones a little bit or squish them. And of course, these are tiny amounts, imperceptible to us, but measurable. So after being frustrated with all these different exercise programs, we're talking walking and swimming and cycling and running and even gym programs, nothing was working. So we decided to just test some real heavy lifting and impact. And we recruited the populations that needed it most. These are people with low bone mass, low to very low bone mass, so what we call osteopenia and osteoporosis. And we included people who had already had a fracture, and we just introduced this program for them very gradually with really good supervision and attention to technique. And we followed them, this was twice a week, 30 minutes. We followed them for 8 months, and then we tested them again. So we measured.
Sorry, did you say they'd already had a fracture or not had a fracture?
A number of people in all of our studies, LIFTMOR for Men and the MedXOP trials, definitely there are people in those studies who had already had fractures, yeah, okay, including spine fractures. So some of them even already had that, what we call the dowager's hump, but scientifically kyphosis.
Okay. Yeah, because this is a really, just on a little tangent here. I've spoken to a number of people, and they worry if exercise is safe, or that type of exercise is safe if they've had a fracture or they're worried about getting one.
Absolutely. And this is the whole reason why nobody had done this before, because we were all worried, me included, that it wouldn't be safe, and particularly for the spine, which is so fragile that it's susceptible to these what we call minimal trauma fractures. So if you can get a fracture from minimal trauma, surely a large load is not good for you. But the fact is, most fractures happen when you're lifting something incorrectly or awkwardly or suddenly. But if you're doing the lifting that we propose, it's highly dependent on your technique, and you are introduced to it gradually. And the amazing thing about bone, and the reason why I'm still stuck on this tissue that I've loved for 30 years, is because it is so adaptable. It's the reason astronauts lose bone when they go into space and their skeleton says, okay, well, I don't need all this bone, I'm going to lose it. It's the same reason that you lose bone if you have bed rest. But it's also the same reason that if you overload it, it will grow and become stronger because it's trying to prevent fractures. So it's a very malleable tissue, but you've got to give it time. It takes ages. The reason we do these long studies is because although it starts to adapt immediately, the first new bone that's created is what's called osteoid. It's just a soft organic kind of a tissue. Doesn't have any mineral in it. It takes a while for the mineral to then go into that tissue and be measurable by DEXA, which is how we measure bone density. So we have to do long studies to give enough time, one for the bone to adapt properly and two for it to be measurable.
So what kind of time periods are we talking about here?
Well, typically, most people don't do an intervention for less than a year because that's a sort of safe time period where it's likely that you'll be able to measure something. We brought that timeline down to 8 months in the LIFTMOR studies and MedXOP because we were reasonably confident that we would be able to see it. And actually they were PhD projects and we had to get these people graduated. So we didn't have time to do 12 months. So it was the minimum that we thought that you needed. But actually, you know, if people do sufficiently intense exercise, you can measure change in 6 months. It's just much less likely.
Yeah, I love this because this is when I was diagnosed with osteoporosis, I kind of went through this deep dive process where I tried to figure out what's going on with this bone, what is it about, and what I kept hearing from my doctors was you don't lay down new bone after 30. All these kind of phrases where your bone is almost like a statue where it's fixed, where you either got it or you don't, especially after 30. But what I realized from my research, and sounds like that's exactly what you've been doing over the years, is that bone does respond, and it responds. Well, it takes time, but it does improve, and it wants to prevent fractures, and so this is really exciting. And so, just going back to technique, you mentioned that the fractures often occur with incorrect technique or sudden movements. And some people have talked about limiting the amount, so saying, oh, there's a maximum of I don't know, I can't remember the number, but people throw out a number like 20 pounds or 30 pounds or kilograms is the maximum you can lift if you have osteoporosis. So what are your thoughts on that?
Well, I guess without being too facetious, is has that person got some kind of crystal ball that nobody else has? There is no magic number, and there is absolutely no way of telling without putting a whole bunch of strain gauges on people's bones, which is highly invasive, and testing every single movement that's possible with those weights. It's just, it is not, that is an air fact, what I call in my family, an air fact. Just pluck that number out of the air. There is no evidence to base on. It might be true, but it could just as easily not be true. And we have plenty of evidence to show that in most cases it's not true.
Okay. So it comes down to the technique
And the person and the state of their bones and how much they've ever lifted before and a million other things that is pretty individual.
All right, so then with the LIFTMOR trials, what kind of numbers, what statistics did you find in terms of improvements in bone mineral density and other kind of factors?
So it's hard to describe the totality of the adaptation of everybody that has done this program in a single number, which is what we would call a mean or an average. Yeah. Because, as you know, a mean is putting everybody's numbers together and coming out with the middle marker, which doesn't show the range. The mean in this case was a mean increase at the spine of 3%, which by comparison with other studies that had showed at the very best, it's sort of a maintenance effect at the spine. They were the next best sort of studies. And our control groups lost. So the net benefit was about 4% at the spine. At the hip, the net benefit was about 2.5%. But the interesting thing at the hip, And the hip is a misnomer, mind you, because the hip is the joint, as you would know, and but we refer to hip fractures. It's not a fracture of the joint, it's a fracture of the proximal femur, or the close end of the thigh bone. So we were looking at the femoral neck, where the thigh bone joins to the pelvis. The increase there was really essentially a maintenance effect, which was a real head scratcher for me, because I thought, we had really loaded these people up. They were lifting pretty heavy, and it made no sense to me why the bone was not adapting. And luckily we had some other software that allowed us to look at these scans in 3D, whereas a bone density scan is a two-dimensional projected image, which is it's not particularly accurate. 3D is what our bones are, and that's what we want to look at. And luckily, the 3D imaging showed us that although we weren't increasing bone density, the density of the mineral in the tissue, we were actually increasing the thickness of the cortex of the bone. And the cool thing was, we increased the thickness of the top edge of the femoral neck, or the lateral cortex, and that's where the fractures propagate. That's where they start. So that's the really cool thing about exercise. It's not a shotgun approach. You don't just do some exercise and your whole skeleton adapts. It is highly targeted. Only the loaded bones adapt, and they adapt in a way that is most likely to improve the strength of the bone. In this case, making it more dense wouldn't have increased the strength of the bone, according to the little metric that we have in our hip, our own little personal monitor there. But getting thicker, the cortex getting thicker, absolutely is going to increase the strength and resist fracture.
There was a question that I received when I told some of the listeners, like, that I'd be talking to you. One of the questions was, exercise, it kind of is related to what you were saying, exercises that help strengthen the spine versus the hip. Is there a difference? What's the difference? How do we if we want to narrow into one or really specialize on one, how would we go about doing that? What have you found?
Well, I mean, it's similar to what I was just saying. You have to load the bones that you want to grow. So, the way to do that is to use the muscles that are crossing those bones that are around there. So when those muscles contract, the bones are loaded. So yeah, it's really not rocket science.
Yeah, well, I found that deadlifts have helped me with my lower back. I found some research on hopping on one leg for kind of honing into the hip. Is that kind of along the lines of what you found?
Yeah, well, like I told you, Tom, I can't give you the program, otherwise I'd have to kill you.
Oh, okay. Well, let's actually kind of talk about kind of the Onero program, because that's what you have created as a result of the trials. You found what worked, what didn't, to what extent people have to exercise, what intensity, how often, and you've created this program. So tell us more about the Onero program.
So we knew that, I knew that bone needed a high intensity load, but it doesn't need a lot of those loads. So once it sees that stimulus, it sort of, obviously the bone cells get fired up and they begin to react. You don't need to keep doing it like a marathon. You do not need to run marathons. In fact, that's probably not very helpful for bone at all, because it can cause micro damage. You need to do a reasonably small number of high enough intensity loads. So that's why we did just 30 minutes twice a week for 8 months, or actually, because bone is use it or lose it. This is a program for life. So, if you stop, you're going to lose the bone you gain. So with that short program, you can only have a few exercises, and we tend to, for that reason, we want them to be as functional as possible. Think movements that people are doing throughout the day, so that they're most useful to people, and use the most muscle, so they're compound movements. And as you say, deadlift is an example. And the reason why we decided that this needed to be a supervised program. Well, one, when we went to publish the LIFTMOR studies, our reviewers were adamant that this had to be a supervised program because they believed that it was just not safe. And I've come round to that way of thinking, that it does need to be supervised, because even I've been doing this program for a long time, and even I feel like I need to be supervised, because the position you're in doesn't allow you to look in a mirror. You need to keep your head in a certain position. And so you can't monitor yourself, even if you do have a mirror. And the errors that you make in these complex lifts are quite subtle, but can make a lot of difference in the loads that are on your bones. So the very best thing you can do is find an Onero provider who can deliver the program to you, teach you the movements, and once you've got that technique right, begin to load you up in a safe manner and get you to the point where you need to be, which is, 80 to 85% of the maximum that you can lift once. So this is heavy, and then keep you there, and adjust things as it needs to occur. Now, also, the reason why it's important to have supervision is because many people who have osteoporosis have heaps of other comorbidities or other things wrong with them. And those are the things that need to be taken into account. I know that there are plenty of people who will be listening and saying, oh, that's all very well, but I've got a really sore back. There's no way in the world I'm doing a deadlift. Well, that's the beauty of having somebody help you, because actually a deadlift is good for a sore back, and they can show you how to do it safely and the way to progress into it to prevent any further injury. And maybe you can't do it for some reason or other, in which case they can modify it. So yeah, it's very much a there is a need for supervision.
Yeah. And so with the Onero program and with exercise, there's also a lot of people who have osteoporosis are taking medications. How does that fit in? Should we do the program after medications, before, during? Does it not matter? What are your thoughts on that?
Yeah, it's the million-dollar question, and that's what I mentioned, the MedXOP trial.
Yeah.
So LIFTMOR and LIFTMOR-M were the basic ones, where we looked at postmenopausal women and older men, and found that Onero was effective for them. MedXOP we specifically did because we wanted to test the same program with and without anti-resorptive medication. And most people at the time were on, and probably still on, Prolia, which is an anti-resorptive drug. It's the one that the doctor will give you every 6 months as an injection in his office. I hypothesized that it was going to be better to do both together, because the exercise is causing the bone building cells to build, and the drugs were inhibiting the cells that cause bone to break down. So I thought together we'd have this fabulous combination and combined effect. Ultimately, it actually didn't really seem to work that way. There didn't seem to be any difference having meds with the exercise as having either the meds or the exercise alone. Both were equal in their effect, and adding them together didn't really seem to improve it more. That was at the spine. At the hip, where, if you remember, I said there's not a huge effect of, or as big effect on BMD at the hip, drugs probably help the BMD a little more if you combine them. So it might be beneficial there, because exercise is increasing the shape and geometry and strength of the bone, and maybe the drugs are improving BMD. So possibly there, but the jury is still out because our sample was quite small. We don't hang our hat on those results because I feel like there's more to be done. We are actually doing another trial led by some endocrinologists in Sydney, who are looking at a new drug called romosozumab, or I believe it's called Avinity, a new drug on the market, and we're having a look in a controlled trial to see what happens there. But That was a very long answer to a short question,
That,
which
that was a great answer. Like that's what I've been wondering, and what a lot of people have been wondering. Like, where does exercise really? How does it compare to the medications? And I heard what you said there about the spine, where they had a similar effect.
yeah, that was very cool, because doctors often say to me, "Well, obviously, exercise isn't going to be as effective as
Yeah.
drugs, is it,
It's
Belinda?"
almost a throwaway thing. It's like, yeah,
And,
yeah, yeah, of course, yeah, do some exercise, whatever, but no medications.
that's
Like,
right. And this showed, I mean, it was almost identical in terms of the effect in bone mineral density at the spine. And so now when doctors say that to me, I say, okay, so we've improved bone the same amount as the drugs, and we've also reduced the risk of falling by improving leg strength and balance and so on. What does drugs do for those last two things?
and what about side effects, right? That
Yeah.
are there any side effects to exercise other than feeling great? Like,
Yeah. Well, and see, a lot of doctors will also say, yes, but then there's the risk of fracture. And, well, no, we've had the bone clinic has been open for over 9 years now, and our fracture record is pretty clean.
yeah,
And also, drugs do not prevent all fractures.
right. So that, yeah, so this is really interesting because I love this because this is kind of what my kind of philosophy is around osteoporosis is to, you know, the drugs are the last resort. Let's do everything else that we can first. Um,
Well, I always say, it's not a competition, and I certainly don't want doctors to feel like I am undermining what they're doing in their care of patients.
yeah,
And certainly, if my mother went to the doctor and she had a T-score of -4, I would be asking them to throw everything at her. There's no harm in trying drugs, and probably much use to be had by trying drugs as well. It doesn't seem to me that there's any harm in combining them. Um, I would certainly be recommending trying everything if you have very low bone mass, but there are lots of people who come to the clinic who do not want to be on drugs. And so they ask me, should I try this first? Well, that's a decision for them. But I can say that we are mostly in at least about 80% of people respond. So this is a really great therapy because, responder rates to drugs are very rarely that good. So you'll almost certainly respond. You might be in that tiny little percent that doesn't respond for whatever reason, but um, if you don't respond by growing bone, probably what's happened is you have lost less, because you cannot not respond to exercise. It's physics and physiology.
yeah. Okay. And so then what's the biggest challenge in getting people to engage more in an exercise approach?
Exactly the same challenges for any medical condition. If somebody goes to the doctor with heart disease and they're at risk of having a heart attack, and he says you need to exercise, and they still don't exercise. So it's purely, motivation. And for most people, they say the reason is time. I'm an example of somebody who says time is the limitation for me to exercise every single day. I need to be better myself at prioritizing it. Everybody needs to prioritize exercise.
Yeah, I think the time one is based on priorities, right? It's a I often refer to it as a value-based objection, where how important is it to you to fix your bones
Yeah.
and to not fracture and not to be crippled potentially down the track? It's like, well, if that's important, let's put in, was it half an hour 2 times a week, right? The Onero program, like that's, I can do that. I remember the days when the Prime Minister used to walk for an hour a day.
Hmm. Yeah.
It's like if the leader of the country can get it in, I'm sure the rest of us can too.
Yeah, exactly.
And so, what would you like to see in the future for Onero and for osteoporosis and for exercise? What's your kind of vision?
Well, the vision is what we're currently trying to implement at the moment with the Stop Fracture study. This is an implementation trial. So as opposed to a clinical trial where you have a therapy that you give to one group and a control with another and you test the outcomes. We already know that this works. So instead of that, the next step I thought was the need to test whether doctors knew about it, because patients largely listen to their doctor. Would they refer? If they referred, would people go? And would they stay? And also some other associated questions like, are they willing to pay for exercise? And we're obviously tracking injuries and fractures and so on. So there's also an efficacy element of it. We want to track and see if people are actually improving their bones. But it's very much a practical attempt to change the model of care and insert Onero into it so that it's not the only tool that doctors have to write a script. They should be referring to Onero and then, if they need to, writing a script. So I guess the future means Onero needs to be more broadly available, and I'm doing my darndest to make that happen. Hope getting people as licensed as possible around the place, and we have extended to around the world. But I'm a professor and I have my day job, so I'm not a salesperson, so I don't sell. I wait for people to come to me, which is a very ineffective way to sell a program. So
Fantastic program. So it's only a matter of time before it gets picked up. And so how can people find it?
Great question. They just need to type in Onero locations and the map will come up in their search. If they click on that, you'll see this map of the world, and you scroll to wherever your location is and zoom in, and you'll see all these little red tags. If you're in Australia, you'll see red tags all over the place, and you zoom in on those to your location, click on the red tag, and the drop down will have the name of the licensee and where exactly they are and how to contact them. If you're in the middle of South America where we don't have anybody, there'll be it's a wasteland. There's no red dots. I'm sorry. So we're waiting for people to contact me and hopefully pick up a license there. There is lots of opportunity there. There's a growing number of licensees in the US, but just enormous opportunity over there, and huge demand. I wish there would be more licenses because we are inundated with requests for licensees in the US and the UK.
Excellent. And so the final question is, when should people be seeking out Onero? Like, what is there a safe T-score? Is there something that's too low a T-score, or at what point do they
No.
seek you out?
So I don't think there's ever a T-score that's too low. I think anybody who has low bone mass should be at least attempting it. And again, the reason why I only license qualified people like physiotherapists and clinical exercise physiologists is so that they can assess their client and then manage them accordingly. We have someone with a T-score of -6 at the clinic. So that person is extremely frail, and we are not gung-ho with her. If we're very, very careful, and the last thing we want to do is cause a fracture. So extremely conservative and managing other conditions. And just doing the very best we can. Improving muscle mass is a great place or muscle strength, great place to start. And balance, we don't want people falling. So there's all sorts of things that we can do to help. And on our path to lifting heavy, and remember, this is a percentage of what somebody's maximum ability is. So Arnold Schwarzenegger's lift is going to be much heavier than mine or that person with a -6 T-score. So it actually might not be that heavy in an absolute sense, but for them it is, and that's the important thing.
Fantastic. Well, thank you for making the time, Belinda, to speak to us. This has been really insightful, and I hope it's helped a lot of people. I love what you're about and what you're doing, and the research. I want to follow along and hear more about it. So everyone watching, reach out to learn more about Onero, and let's use exercise to strengthen those bones and live a better life.
Great.